If a surgeon has ever looked at you across a desk, slid a form in your direction, and said the words "you need this operation," I want you to remember this moment right now, because what you are about to hear could be the most important thing you listen to before you ever sign anything. And if this channel has given you something useful before, hit that subscribe button right now, leave a like, and drop a comment below, because that is what keeps this information reaching the people who truly need it. I'm Dr. Mercer, and this channel exists to bring you the latest evidence-based research on senior health, simplified and designed for adults over 60. Stay with me through this entire video, because by the end you will have 5 specific questions that could protect your life, your independence, and your quality of recovery in ways most patients never even think to ask. Let's get straight into it. Most people walk into a surgical consultation believing that if a doctor recommends an operation, that recommendation is automatically the right one. The doctor has the training. The hospital has the equipment. The paperwork is already prepared. And so you sign. I understand that completely. The authority of medicine is real, and the trust patients place in their doctors is not misplaced. But here is what 2 decades of surgical practice taught me, and what I wish someone had explained to patients far sooner. The older your body is, the harder it fights simply to survive an operation. Not the disease itself. The operation. That distinction matters more than almost anything else in this conversation. Think of it this way. Take a vehicle with 20,000 kilometers on it and a vehicle with 300,000 kilometers, and put them through the exact same stress test. You would never expect the same result. And yet for decades, medicine applied the same surgical protocols, the same recovery timelines, and the same expectations to a 70-year-old body as to a 40-year-old one. That is starting to change, but not nearly fast enough. Here is what actually happens inside an older body the moment it goes under general anesthesia. The heart works harder to compensate. The lungs take significantly longer to clear the anesthetic agents. The kidneys slow their processing of medications. And the brain, this is the one that genuinely surprises people, the brain becomes temporarily disoriented in ways that can persist for weeks or even months. Physicians call this postoperative cognitive dysfunction. In patients over 70, it occurs far more often than anyone openly acknowledges. Now I want to be precise about something before we go further, because I am not here to frighten anyone away from surgery. Age alone is not a reason to avoid an operation. I have operated on patients in their 80s who recovered faster than some of my 50-year-old patients. Age is a number. Frailty is not. Frailty is a clinical term with a specific meaning. It describes a body whose physiological reserve has dropped below a critical threshold, where the margin for recovery has narrowed considerably. Approximately 40% of adults over 75 show measurable signs of frailty. That figure rises to nearly 60% in those over 85. So the real question is never simply can this patient survive the operation. The real question is can this patient survive the recovery. Those are 2 entirely different things, and that distinction is going to matter a great deal right now. The first surgery I need to walk you through is open heart surgery in frail patients. Coronary artery bypass grafting, which surgeons refer to as CABG, is one of the most common major operations performed on older adults. The principle is straightforward. Arteries are blocked, so we reroute the blood flow. For the right patient in the right condition, it works remarkably well. But here is what the surgical brochure does not show you. Open heart surgery requires stopping your heart completely. You are placed on a bypass machine, a device that performs the work of your heart and lungs while the surgeon operates. For a 60-year-old in solid cardiovascular health, that is manageable. For a 78-year-old with kidney disease, early cognitive decline, and diabetes, that bypass machine represents a simultaneous assault on every major organ system in the body. Published studies show that in frail elderly patients, open heart surgery carries a 30 to 40% risk of serious complications including stroke, kidney failure, prolonged confusion, and extended time on mechanical ventilation. And up to 15% of high-risk elderly patients do not survive the first 30 days after this surgery. Not from the underlying heart disease. From the operation itself. I sat with a patient I will call Raymond. He was 76, a retired schoolteacher, still sharp, still walking every morning. 3 cardiologists had recommended bypass surgery for a blocked coronary artery. When I reviewed his full profile, his kidney function, his frailty assessment, his cognitive baseline, I presented him with an option none of the previous physicians had mentioned. A procedure called TAVI, transcatheter aortic valve implantation, a catheter-based intervention that never requires stopping the heart or opening the chest. Raymond chose it. His recovery took 11 days instead of the 6 to 8 weeks traditional surgery would have demanded. The question every patient should ask before open heart surgery is simply this: am I a candidate for a less invasive approach? That one question can change everything. The second surgery is aggressive spinal fusion. Back pain in your 60s and 70s is nearly universal. I do not know a single patient over 70 who has not mentioned their back at some point. And the solution increasingly offered is spinal surgery, multi-level fusions, hardware inserted along the length of the spine, complex decompressions. Some spinal surgeries are absolutely necessary and I will not suggest otherwise. A spinal cord being actively compressed, causing loss of bladder function or progressive paralysis, requires surgical intervention without delay. But elective spinal fusion for chronic back pain in elderly patients, the evidence here is genuinely troubling. A major study published in the journal Spine found that in patients over 65, complex spinal fusion carried a complication rate exceeding 40%. 40%. And the complications were not minor. Blood clots, deep infections, hardware failure, and something called adjacent segment disease, where the vertebrae above and below the fused section begin breaking down because the natural mechanics of the spine have been permanently altered. One segment is held rigid and the surrounding structures absorb the consequences. What frustrates me most about this data is the pain relief outcome. Studies consistently show that for many elderly patients with degenerative spine disease, aggressive surgical fusion provides no better long-term pain relief than a structured program of physical therapy combined with targeted injections. No better outcomes, but with dramatically higher risk attached. Have you ever been told that surgery was your only option for back pain? Write yes or no in the comments right now. I want to know how many of you have heard those exact words. The third surgery is major cancer resection in frail elderly patients. This is the most difficult to discuss, because when someone hears the word cancer, the instinct is immediate and powerful. Remove it. Cut it out. Eliminate it entirely. I understand that instinct completely. But 2 decades in the operating room have taught me something that took years to fully accept. The goal of treatment is not simply to remove the tumor. The goal is to give the patient more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient works against that goal rather than toward it. A landmark analysis from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced what researchers call failure to rescue. A complication arose that the weakened body simply could not overcome. The surgery technically succeeded. The patient did not. The question worth asking your oncologist directly is this: if we do not operate, what does watchful waiting, radiation, or targeted therapy look like for someone with my age and my specific health profile? That question opens a door that many patients never even knew existed, and sometimes what lies behind that door is genuinely the better path. Before I continue, I need to say something important and I need you to hear it clearly. Nothing in this video is a reason to refuse treatment, cancel a scheduled procedure, or make any medical decision without your physician. What I am giving you is information and questions. The decisions belong to you and your doctor together, with full information on the table. Do not make unilateral changes based on what you hear here. Always have that conversation first. The fourth surgery is elective joint replacement in patients with multiple serious health conditions. Hip and knee replacements are among the most genuinely successful operations ever developed. For the right patient, a new hip transforms quality of life in ways that are remarkable to witness. But the word elective means you have time. Time to think carefully, time to prepare, and most importantly, time to ask whether this is the right moment for your specific body in its current condition. In patients over 75 with 3 or more serious coexisting conditions such as heart disease, diabetes, chronic kidney disease, or obesity, elective joint replacement carries significantly elevated risk. Blood clots are the most serious danger. Deep vein thrombosis, clots forming in the legs that can travel to the lungs and become life-threatening pulmonary emboli, occurs at substantially higher rates in elderly patients with compromised circulation. The critical point here is not whether to have the surgery. For many people it is absolutely the right choice. The critical point is whether your body is in the best possible condition before you proceed. Optimizing blood pressure, blood sugar, cardiovascular health, and physical strength before an elective operation can reduce complication rates dramatically. Some hospitals now require a formal prehabilitation program before scheduling these operations for high-risk elderly patients. That is exactly the right approach, and if your physician has not mentioned prehabilitation to you, that is a conversation worth starting. The fifth surgery is emergency abdominal surgery, and this one is different from everything else on this list because you do not choose it. A perforated bowel, internal bleeding, a ruptured appendix, these situations do not wait for a calm office conversation. But here is precisely why it belongs here. Knowing the risks before an emergency happens changes how families make decisions in the most terrifying moments. Emergency abdominal surgery in patients over 75 carries mortality rates between 30 and 50% in the most severe presentations. Not because surgeons are unskilled. Because an elderly body under sudden catastrophic trauma is fighting on too many fronts at once. The inflammatory response that a younger body contains within days can spiral in an older body into systemic inflammatory response syndrome, where organs begin failing in sequence. So what can you actually do with this information? 2 things. First, do not ignore abdominal symptoms. Persistent pain, significant bloating, or meaningful changes in bowel habits in anyone over 60 deserve prompt medical attention. Catching problems early means treating them before they become emergencies, and that single habit can genuinely change the outcome. Second, have the conversation with your family now. Not in a hospital corridor at midnight with a surgeon you have never met standing in front of you. Now. What are your wishes if emergency surgery becomes the only option? What quality of life matters most to you? These conversations are not morbid. They are among the most loving things you can do for the people who will be standing in that corridor. Now let me give you the concrete steps that matter most. Step 1. Before any major surgery, ask your surgeon directly, what happens if I do not have this operation? A surgeon who gives you an honest answer to that question is a surgeon worth trusting. If the answer is that nothing urgent changes in the next 6 to 12 months, you have time to think, time to get a second opinion, and time to prepare your body properly. Step 2. Ask whether a less invasive alternative exists. Medicine has changed enormously in the last 15 years. Robotic procedures, endoscopic interventions, catheter-based approaches. Options that did not exist a decade ago are now available in most major medical centers. Step 3. Ask what recovery realistically looks like for someone your age with your specific health profile. Not the average patient. You. Your heart, your kidneys, your current medications, your home situation. The answer should be specific. If it sounds generic, ask again. Step 4. Ask your surgeon their personal complication rate for this procedure in patients over 70. Surgeons track these numbers. A confident and honest surgeon will tell you. If they seem uncomfortable with the question, that discomfort is itself meaningful information. Step 5. Request a formal frailty assessment before any elective procedure. This is a standardized clinical evaluation of your body's reserve and recovery capacity. Many hospitals offer it. Many patients never know to ask for it. One clarification before we close, because credibility matters more to me than making a persuasive argument. Everything discussed today applies to elective and planned surgeries in patients where frailty or multiple health conditions are present. If you are facing a genuine emergency, if you have an active cardiac event, an acute perforation, uncontrolled internal bleeding, surgery may be the only option and the right one. The message here is not to avoid surgery. Surgery saves lives every single day, and I have been privileged to be part of that. The message is to be an active participant in your own care. A surgical recommendation is not a verdict. It is the beginning of a conversation. You have the right to ask every question, request every alternative, and take every day you need to make a decision with clear eyes and full information. The surgeon holds the scalpel. You hold the choice. If this video gave you something useful, please take a moment right now to hit the like button, leave a comment telling me which of these 5 surgeries surprised you most, and share this with someone you love who may be facing a surgical decision. Subscribe if you have not already, and I will see you in the next one. Take good care of yourselves.